Good afternoon, everyone. My name is Phoebe. I sit on the BC Health Coalition Steering Committee as a representative of the BC Federation of Students. We are a provincial students union, essentially, with 14 different unions across the province. More importantly, we represent all college, university, trade students. On behalf of the steering committee, I'd like to thank all of you for joining today. I know it's bright and sunny outside, but here we are in a Zoom meeting. All our passion for better public health is all encapsulated in our dedication to this time. We're delighted that you are here to build power for public health care. And there are many, many more that needs to join us, and we are looking forward to having you today. But before we move forward, the BC Health Coalition acknowledges that we are based on the unceded and traditional territories of Coast Salish nations of Musqueam, Tsleil-Waututh, and Squamish. We also acknowledge that many territories and lands across Turtle Island that are joining us from. We are honored to be here as guests on this land and that Indigenous peoples have cared for and continue to care for. Particularly, our federation is also located at the Kakite First Nations. I saw some folks here that are in the same First Nation territories. Shout out to you folks. We invite you to take a moment to think about where you presently live and honor the people of the land. Think about your relation to the place you live, work, and interact. This is our inquiry to honor the past and present and to stay connected to decolonization practices. We invite you to share, and I know I've seen some people have already done so, but we continue to invite you to share in the chat the name of the territorial land from where you are connecting from as part of this acknowledgement. Yeah, I think that's something that we can move forward. Thank you, everyone, again. Please drop it in the chat if you want to share where you're coming from. I think we're moving on to the next part of this.
Thanks, Phoebe.
Mm-hmm.
So I'm going to start a bit about, do a bit of framing for this event. So first of all, thank you for joining us for this meeting, launching the BCHC's listening campaign. This campaign will focus not only on just listening to you, but inviting you to come on board as we build power collectively towards recommitting to a better public healthcare system. Why do we need to build power collectively? Well, Canada's universal public healthcare system was won by organized people. Community organizing in the poorest prairie regions of Canada in the 60s and 70s, despite fierce opposition from physicians and insurance companies, brought together a generation who imagined a world where everyone would have access to the healthcare they need. The promise of public healthcare was supposed to actually go beyond just covering physician services to actually covering vision, dental, and yes, drugs. However, that promise has stalled, and even what we have right now is being challenged. Today, we see staffing and access issues all across healthcare, and we know that the most equity-deserving communities are actually the least likely to find the care they need. We see profit-driven long-term care facilities making record profits from taxpayer money that should actually be going to care. We see contracts being given out to for-profit corporations like TELUS for virtual healthcare or for specialized mental health services like eating disorders, when those same corporations are actually the least qualified to deliver those services. Meanwhile, physicians and their lobbyists keep calling for more and more money when BC already has more family doctors per capita than ever before, instead of investing into neighborhood-based community health centers that can actually begin to address the lack of primary care access. But make no mistake, all these issues are actually not inherent to our universal public healthcare system. Decades of underfunding, privatization of public services, contracting out, and lobbying by profit-driven corporations and their allies have led us to this. Instead, we need to recommit to a healthy, universal, publicly funded healthcare system delivered by unionized workers invested in the common good. To do that, we must build organized people power at the scale necessary to meet the challenge before us. So this is where all of you come in. That means everyone on this call, your families, your coworkers, your faith groups. Organizing ourselves is even more important in a provincial election year. We know for-profit corporations, physicians associations, and other entrenched actors who are interested in fragmenting our public healthcare system are already busy lobbying. So to push back against that lobbying, our organized voices calling for an expanded, improved, and healthy public healthcare system are more important than ever before. Of course, building true transformative power involves fights and victories beyond the election too. So no matter who's in government this November, we need your participation in your community to keep up the public pressure for the changes we need. But let's take a step back. It all starts first with listening, and that's the point of this event. In this meeting, we'll talk about how we plan to listen to you. You'll get a chance to be part of a listening meeting with others. And then you'll also learn about how we can help you lead these meetings in your community. So through this listening and through building this power collectively, we can organize towards a new vision and promise for better public healthcare in BC. We all deserve better public healthcare, so let's build towards it. So with that, I'm going to pass it on to our organizer, Audrey, who will go more into what we're planning to actually do at this meeting.
And hello, good afternoon, everyone. My name is Audrey Gay. I use she, her pronouns, and I organize with the BC Health Coalition. Thanks so much for joining us today. We're excited to be together. I'm working behind the scenes at the same time to create our breakout groups for a little bit. So hopefully we'll get those going in time for our conversations. But I'm going to just start by taking a look at our agenda for the day and then talking us through the organizing strategy that we've created that encompasses this listening campaign, so that we all can know what we're doing. So let me just go ahead. I'm going to share my screen and go back to the slides. And hopefully that's coming up on your screen, our agenda. So we're in item 3 now. We're going to talk about our organizing strategy overview. Then we're going to talk a little bit more about house meetings, which is the key tool in our toolbox as part of the listening campaign. And we're going to actually do them together today. We're going to break out into small groups and talk to each other about our experiences with healthcare. And that'll be kind of an experiment to experience what this is and that we're going to be asking you to do as part of this campaign, and also just a chance to connect with each other. And then we're going to come back together, think through some of what we've learned and try to make sense of it. And then we're going to talk more about next steps and how you can be involved. So that's where we're heading together. So this chart lays out the first stage in our organizing strategy, and it's really a listening campaign that sets us up for our provincial election campaign leading up to October. So October 2024 is a provincial election year this year, and we know that healthcare is top of mind across the province, and we know that it's going to be a key election issue. So we want to be ready to have people, everyday citizens, members of the public, engaged meaningfully in that public conversation. And when we say we want to build power, what that really means is that we want to build relationships. And so it's kind of countercultural. In organizing, we ask, who are my people, before we ask, what are my issues? And that's what we're trying to do with this first stage of our organizing strategy. So the heart of the listening campaign is really about building relationships, getting connected to leaders in communities across BC, and finding out who has energy to be involved in reclaiming our public healthcare system. So we'll know we'll have been successful if we start getting a sense of who in local communities might start forming teams and be interested in looking at actions together. And how are we going to do this, you might ask? Well, we're going to spend a bit over 2 months between February and April. inviting you to organize house meetings. And put really simply, house meetings are small group conversations that build relationships, find leaders, unearth stories that call for change, and identify areas of shared action. We're going to talk a lot more about this throughout the meeting, and as Usman said, you'll get a chance to try it out in breakouts. We've created a listening toolkit that you'll leave with today that has all the information you need to do that. And then we'll organize a training next week. It's already set for February 15th at the same time, same place next week. That if you're interested in attending, will make you feel extra confident in this process. But really, over the next 2 months, the amount of power we build really hinges on all of your willingness and the willingness of other people in our network that aren't here today to go back to your family, friends, neighbors, organizations, colleagues, and ask people to have an intentional conversation about their experiences with our healthcare system. And then on April 25th, we'll come back together, and everyone who's participated so far in house meetings and anyone who's here today is invited to join us for an action planning town hall. And that's really a participatory democracy exercise where we're going to report back all the key themes and stories that we've heard. And we'll get a chance to touch base to see if that resonates and that lands with you. And then collectively, we'll get a chance to vote with our energy. And so identifying what are the priority areas that you have some time and energy to put some energy towards. And that's really how we'll know what we can focus on in the year ahead. And so that's a really important date, and I want to invite you to put that in your calendar right now, April 25th, I think at 1 p.m. And just plan to be there and plan to come back and be part of that next step of co-creating our priorities for the next year. And we're going to use everything that comes up on April 25th and go back to our health policy experts and practitioners and craft a healthcare platform, which is going to be really the vision, a people's vision for a strong public healthcare system. And that will be the gold standard that we use to evaluate the commitments from elected officials or candidates in the provincial election. And it'll be kind of a tool for communities to use as they go out in the public places and build support for public healthcare in the year. And so hopefully we'll get back to you with more details of what stage 2 will look like between, following May. But we're hoping it will involve in-person town halls in communities across BC that are focused on public solutions, as well as trainings for local groups to think about how to plan actions and campaigns locally. And maybe other things, and we're open to ideas that come up from communities. And so that's really the plan. And what we're really focused on today is this next 2 months, this listening season, and the key part of that being house meetings. So I'm gonna, before we dive into that, I just want to tell you right away how we're going to ask you to get involved so that you can be thinking about it as we move along here today. My colleague Usman is going to put a link in the chat to our commitment card. And this is kind of our action, a call to action. It's a Google form that you can feel free to open right away and check out. And you'll see that there's different sections on it. And I'm just going to stress this first section right now. And that's about participating in this listening campaign by being part of house meetings. So we want you to consider this. And of course, as we said, we're going to talk a lot more about what that looks like. And so, don't make a commitment right now, but have it in the back of your mind as we're going into our breakout conversations. And we're going to come back to this later on in the agenda. And I think I'm going to stop sharing my screen now, and I'm going to pass it off to Colleen Fuller, who's been a longtime member and former board member of Reach Community Health Center and sits on our steering committee at the Health Coalition. And Colleen has great experience leading listening campaigns and house meetings in the context of Reach Community Health Center. I've asked her to share a bit her experience and help us imagine what that looks like. And hopefully that helps give you a sense of the power that is behind this approach. So over to you, Colleen.
Okay, can you hear me? Hello?
Yep.
Yes.
Okay. Yeah, I have been on the board of directors of REACH, and I'm glad to see that there are several people here from REACH as well. We had in 2012 and 2013, actually 2013, we began working with the Metro Vancouver Alliance, which at that time was organizing listening campaigns across the city of Vancouver, and our campaign was in healthcare, and they helped us organize what we called Listening for Direction. And it was one of the best campaigns I've ever been involved in. It was I learned a lot, and I think that it had a really positive impact on REACH in terms of how we identified what our priorities were as an organization. And I'm just going to give a very brief overview of what that looked like, what this campaign looked like. So we began organizing in 2013. We started by mapping the community organizations which are in our catchment area in East Vancouver. And we identified organizations that were membership based. So these weren't service providers that did not have a membership. We learned about their mandates, what they did. We began interviewing whoever was in charge, mainly usually the executive director of those organizations, to get support for what we were doing for the Listening for Direction project, and get them basically to help us get access to their members, because those were the people that we were going to be talking to. These organizations included a lot of faith groups, unions, co-ops, seniors organizations, and groups like Sanctuary Health, and right across the board, really. The listening sessions were organized. They weren't necessarily in somebody's house. We would meet anywhere, in church basements, in community organizations like Britannia or Hastings.
Can you get me water, Bill?
And so we had approached organizations or approached groups. There'd be usually between 6 and 10 people in each session. We had 3 questions that we put to the group, and the questions are very important. The questions were, what are the key issues that are facing you in your life? What are the key challenges in your life? We asked them to name 2 or 3 changes that would have a positive impact, that would make their lives easier, or for themselves individually, their families, their communities. And the last question was, what can they do, or what could we do, what could REACH do to help them get those changes? What would bring those changes about, and how do you get those changes? And so those were the questions. We didn't ask yes and no questions. We basically left the questions quite wide open. And one of the key things I learned is that you cannot anticipate what the answers are. You have to be ready yourself to be challenged by the answers. Somebody says, what is REACH? REACH is a community health center on Commercial Drive, and we provide a range of services, medical, dental. We have a pharmacy. We have a multicultural family center, which is now being reoriented, in part based on what I'm just describing to you now, actually. We met with 30 organizations altogether, and these were and we met with their members. The listening sessions identified a number of issues. We thought that people were going to say, the best thing that could happen in my life is if I had a doctor, but that was not the case. And people identified a range of issues. One was poverty, was a big one, housing, access to support services, including healthcare, but not just healthcare. And the access to health services was particularly a priority issue for new arrivals in Vancouver, and not just immigrants, not just refugees that were coming to Vancouver who are specifically challenged in terms of getting access to healthcare, but also Indigenous youth who are arriving in Vancouver, seniors, and so forth. So all of these issues were key for them. For seniors, it was people who were afraid of losing their housing, losing their independence, the inadequate support services that were available to that population. An eye-opener for me was the discussions which came up in group after group around mental health. And what I and most of us thought that when people talked about mental health, that the thing that would help them deal with the stresses and so forth that are part of that people would be saying we want health counseling, we want access to psychiatry. No, it was access to secure housing, food security, transportation that didn't cost an arm and a leg, child care, child support services, all of these things that contribute to mental distress. Now, the impact that this had on REACH was very significant, because we realized that we really had to start focusing on social determinants of health, that our healthcare services are important, but so are all of the range of things that contribute to ensuring that we don't end up in the doctor's office and don't end up needing healthcare. And those are the determinants of health: secure housing, poverty, racism, and that those kinds of services. That really had a huge impact on our board. We began developing an approach to the Ministry of Health to ensure that we had funding that would enable us to address those types of issues that people were confronting in their everyday lives. People in our community, people that included our own patients and so forth. It was a very, very rewarding experience for all of us. There were about 20 of us that participated in that exercise. It had a big impact on all of us, on how we see our community, how we view what is the role that REACH should be playing in our community, not just in the provision of healthcare, but in the provision of this broad range of services that overlap between health and social services. I'm going to leave it there. And one of the other lessons that I want to stress is that you can't, as I mentioned before, you can't anticipate the answers. If you get the answers that you were anticipating, you're not asking the right questions. That's it.
Thanks so much, Colleen. I think I've got our breakout groups mostly set up and even-ish. I'm just gonna give us a few more detailed instructions before we go off into these groups. So these are 30-minute conversations, and each group will have a leader. And small group leaders, you should know who you are right now at this point, so please identify yourself when you go into your breakout room. And the small group leader is really there to guide the conversation, keep track of time, take notes, and then submit the report back. So we have a form that we've asked them to fill out with key themes and stories that emerge from your conversation. That's one of the main ways that we're going to be capturing what comes up in these breakouts. your task as a group is also to save a little bit of time at the end to choose one story from your group that you'd like to share with a full meeting when we come back together. Now, I'll say right ahead that we won't have time to hear from each group, and that's why we have the report back forms. And in the commitment cards, there's also an opportunity for you to share your story again, just to make sure that it's captured if if it doesn't come out in a full group. And then just note to the breakout group leaders, focus on questions 1 to 3, because we only do have 30 minutes for this conversation today. And so if you don't get to 4 and 5, that's okay, because we'll get to it in a different way in this meeting. The discussion questions should be in the chat. Are they in there? Or just before we start the breakouts, I want to make sure that they get in there. So we'll put the questions in the chat before we get going. I think we've got about 6 to 8 members for each breakout room, so that just small group leaders think about how to manage the 30 minutes with that. It's a bit larger than we had expected. But that's a good problem to have, because we have many more people here than we thought were showing up. So I think we're just going to go ahead and I'm going to open the rooms, and we'll come back at just about 2 p.m. together. Okay, have fun.
Good afternoon, everyone. My name is David Ravensbergen. I am a staff organizer with the Council of Canadians, and I sit on the steering committee of the Health Coalition as well. I'm based on unceded, stolen Musqueam, Squamish, and Tsleil-Waututh territory in Vancouver. So we're just going to take a few minutes here to collect some stories, some highlights from your group discussions, and just a reminder that we won't have time for everyone, for every group stories, but we are submitting the notes through the feedback form. So the stories will be recorded as part of this listening session. I'm going to pass it to Carolyn Harrow now.
Oh, okay. I'm Caroline Harker. Yes, I was sick over Christmas, before Christmas, and I live in Osoyoos. So my daughter drove me to the hospital, but at 4:30, we looked it up and emergency was closed at 4:30. So in Oliver, that is, because we had to go, there's nothing here in Osoyoos, so we had to go to Oliver. From Oliver, it was closed, we had to go to Penticton. I was in Penticton, they sent me back to Oliver. My daughter drove me back. They got me a room there, not emergency. Got to the room, the doctor came and said, no, put me back on an ambulance and sent me back to Penticton. And I had cavital pneumonia and I had COVID. By the time I got to the hospital, they discovered I had sepsis. Now the fight is on to bring me back. I basically was crossing the other side. The doctors asked my husband if we had written anything in case something happened to me and I passed away. My husband was in shock. Like, here we were going back and forth, emergency rooms. And I ended up in ICU in Penticton. I spent 11 days there in isolation. Then I got sent home and I went back 5 days later because I still had liquid in my lungs and I was still suffering. So I ended up staying a total of 3 weeks in hospital. And that's the problem. We have nothing here. We don't have a hospital in Osoyoos. We don't even have a clinic. We have to go to Oliver. Oliver closes the emergency, and that's a huge problem. And then we have to go to Penticton. But the doctors and the nurses in Penticton are wonderful. So I just have nothing but praise for them. And if I could help them, I would. And that's my story, my beef about the system.
Carolyn, that is a harrowing story. Thank you for sharing. I am going to pass it along to Gail Harmer, please. Gail, if you're there, please unmute. Gail, I think you're still muted.
Sorry about that, folks. I'm 82 years old, and my background is medical social work. So you can imagine, I was doing medical social work long before, there were several years before this country had Medicare. So I cut my teeth performing my professional services mostly on welfare wards. Do you people understand that in the old days, when people had no medical coverage and there was no public funding for hospitals, people that were very, very sick and ended up in hospital were almost at death's door. And they were put on special wards that were only set up for them. They weren't allowed to mingle with other patients. And they were serviced by the interns and residents under the supervision of 2 or 3 specialists in the area. So I would go with the team 5 days out of the week from bed to bed to bed. Guess where those beds were often? They were in the hallways and they were in the sunrooms. No privacy, nothing, right? And also that people were discharged from hospital and there weren't services available for them. The long-term care facilities were nursing homes. They were all privately run. They weren't even supervised, anything, right? It was terrible. So when 2 or 3 years later, Judy LaMarche got us all to get, all Canadians were going to have to apply for something called social insurance numbers in anticipation of our getting a federal health care plan. So I spent many hours signing people up, I'm telling you, because a lot of people were single moms and pensioners who I met and worked with. If they weren't in beds, they were sitting on wooden benches in the outpatient department for hours, waiting for one of the private physicians to give 2 or 3 minutes of their precious time to come down and see them there. So I was busy signing up all those people. But we were promised so many things with public health care that never materialized. We're still waiting for these services, folks. So it is very important that we at the grassroots level support the coalition and get ordinary people in our communities organized, thinking about it, get their personal input, et cetera, get them involved, get them exercising their power. Things have got to improve. We had these expectations. They haven't been delivered. And before I go, I want to see movement on that part. I want to see us move towards it, and it won't happen unless you and I and all of our neighbors get together and are really well organized before every election. We've got things ready to go and we know who it is we want to run. Sorry, I got on my high horse there.
Very much appreciated, Gail. It's great to get that historical perspective and to connect the struggle for healthcare today to this long lineage of struggle for proper care. I'm going to pass the mic to Patience Magagula. If you're there, please go ahead and unmute.
Yeah, my name is Patience again. I have so many stories since I came to Canada. I came to Canada in 2007 as a refugee, and coming from a war-zone country. I was so fortunate that I could speak English. After witnessing stigma and discrimination in my community, I founded an organization to help those who don't have a voice. I'm now a voice of the voiceless in this community, and I'm fighting stigma in my community, which is happening every day. And I've gone through so much in healthcare, accessing treatment. And right now I cannot access care where I live. I have to call Uber. The moment I call an ambulance, I'm taken to the nearest hospital. And that's what is happening to my entire community. We cannot use all the support we have here because of stigma we're facing in healthcare. It has been ongoing for many years. We had a number of HIV organizations around the community. Some of them are closing because of lack of funding. And we tried to fight stigma in healthcare. It never happened. And recently we got funding where we have collaborated with one research team. We're trying to work together as a community. Our people are dying. HIV is not by choice, it's not by lifestyle, it's not a killer disease anymore. And we are losing people in our community. There was a time, 2017, we lost like 13 people. And we all go through that pain. Your pain is my pain. So for me, I'm asking all of you as a community, let's come together and fight this stigma going on in healthcare. It's not all about ACP community. It's all about the entire community. There was a time I was advocating for one of our ladies, and I just found out that the nurses, they were calling names, people, the drug users, and they never even treated them like human beings. And we need to fight this as a community. We are losing brothers and sisters. We are losing parents in healthcare because of this stigma and discrimination. It's our duty, all of us, to come together. So we tried to educate outgoing students from UPC. We partnered with UPC sometime to find out how best we can educate healthcare personnel who are graduating. And that program worked well, but the lady was working there, retired. So we wanted that program to continue so that we could continue educating healthcare providers. And at this point in time, we are planning to, once we get funding, we are planning to educate healthcare personnel, especially educating them on cultural safety. And we want to train them. We are community experts. We are living with HIV. I've been living with HIV for more than 20 years. I'm living a healthy life. But the moment they see my face, one time I was in the hallway for 3 days, and the nurses, without confidentiality, they were shouting at me, "We don't have your HIV meds." And my son brought my medication. I couldn't access medication from home. They said, "We cannot allow you to take your medication from home." And I stayed like for 3 days without medication until my doctor intervened. And I was in the hallway and they couldn't even give me a bed because of my HIV status. Nurses were coming all the time, yelling, calling me names. And this is ongoing. And we cannot do it alone. We need all of you to come together and join us and save lives. Thank you.
Thank you so much for sharing that, patience, and for underlining the importance of combating discrimination and ensuring health justice for stigmatized patients, HIV patients, and others. So I'm going to wrap up our story sharing portion. I'm sure there are many, many other excellent stories in this group. We'll be doing our best to capture those and use that to inform the next stages of this campaign. For now, I am going to pass it on to Ayandri.
Hey folks, thank you for joining us today. And so I'm going to be talking quickly about why this is happening, why we are here and experiencing this state of healthcare. And, I just want to let everyone know I did not collude with Gail on my portion. I have just met her, but she really led me into this. So here, Medicare has been seen as one of the greatest achievements in this country for a long time. So why are we here? The part of the story you may not have been told is that this project was stopped from being fully realized. The first phase of Medicare was the removal of financial barriers between those giving the services and those receiving them. But Tommy Douglas and the movements organizing for public health, for the public health system, always saw this as the first phase of Medicare, as just a prelude to a more ambitious second phase. Though difficult to achieve, the vision involved a fundamental restructuring of our healthcare delivery system, with a much greater focus on illness prevention, health promotion, and the policies that required to address the social determinants of health. Again, did not hear Colleen's portion before this. Here's a quote from Tommy Douglas: "Let's not forget that the ultimate goal of Medicare must be to keep people well rather than patching them up when they get sick." Our current system does not guarantee access to primary care. Just for example, it was set up to pay doctors to set up businesses. Prevention and primary care is actually essential to keeping costs controlled, as emergency care is by far the most expensive type of care. Prevention and primary care is actually essential to just our wellness altogether. And in the past couple of decades, because of these cracks in this incomplete system, we have seen an invasion and increase of for-profit investor-owned service deliveries, and even and corporations leeching necessary resources and funding out of the system. Now, where we are now, with the weight of the pandemic, an aging population, and increased inequality, these areas of the healthcare system that were never completed means that the entire system, and that's what, so many of the stories we're discussing around emergency care, is completely being threatened. And the Anti-Public Healthcare Coalition has sprung back to life, bent on discrediting and undermining public healthcare. Claims that Medicare is fiscally and economically sustainable are unfounded, but they are used to persuade a reluctant public that there is no choice but to accept privatized healthcare. They have sought with a lot of success to frame the debate as between defending an untenable status quo or fixing public healthcare by introducing private-public partnerships and innovative corporate solutions. Though they never admit it, public healthcare is more effective at delivering care and ensuring that healthcare systems prioritize health, because it's structured around prioritizing health. Whereas a private health system driven by profit means worse access to care, longer wait times. And I don't think I could explain it better than what Gail was describing in the beginning of, or before we spoke to this. So how do we address this? How do we address these issues that we're experiencing? How do we set up? How do we get accessible primary care? How do we address the state of long-term care and emergency room closures and wait times? How do we do this in our current situation with the forces that are against us? We can do this by completing the original vision of Medicare, building on the proven administrative efficiencies of a single payer system administrated by the provinces. We can expand public health care beyond doctors and hospitals into pharmacare, home care, and dental care, to reorient public health care around primary care and community care, the social determinants of health. And how do we win the power to do that? And I think this feels hard, but when we think about how the first phase was built, we give a lot of credit to one person and one party, but as Usman spoke to, it was grassroots organizing. It was a movement that took decades. When we won the first phase of Medicare, the same forces lined up against us. In fact, they spent more on the anti-Medicare campaign than any election campaign in Canadian history at that time. And it was like, it went on for years. I'm not going to pretend it's an easy fight, but the well-funded propaganda campaign against Medicare severely underestimated the strength of the grassroots and the resulting political consciousness. In my role as campaigner at the BC Health Coalition, I've met many people over the years who tell me stories of sitting on their parents' and grandparents' knees as they held meetings in homes, barns, and churches. Their stories convey the sense that it was fought for and won on the strength of people. In rural Saskatchewan, when we're also thinking about access and health access to rural communities, healthcare was won by rural communities. And with the idea of access, community access, rank and file workers, farmers, agrarian radicals, and other movements continued grassroots organizing. They door knocked, they held reading groups, they had community dinners, they took direct action, they set up their own clinics. The CCF, led by Tommy Douglas, was emboldened by these movements to stay principled in their approach. And that is how we won that first leg. So the reality is we can't count on governments. We have to embolden them as a grassroots. So what we're doing today is we're launching the grassroots campaign. We are relaunching the grassroots campaign that once won the first phase of Medicare, and organizing for a healthcare system that is able to address our needs now. Our first step is the listening campaign, including the house meetings and town halls Audrey described in the beginning of this. So first, we're building community power. We're going to you and deciding together how we're going to approach this. So I will move it over to Audrey.
Actually, Usman goes next.
Oh,
Thanks,
sorry,
Ayandri.
Usman. Yes,
Yeah.
Yeah,
Usman.
we're going to
The
wrap up
speaker
in
of
a
the
couple
next
minutes, but we just want to reiterate how you can be involved. So take it away, Usman.
Thanks, Ayandri. So you've had a sneak peek at what a house meeting can look like through your breakout groups. And just like you were saying, Ayandri, it was conversations exactly like these in farmers cooperatives and faith houses and union halls that really built the movement for public health care. And we can be part of rebuilding that kind of movement here. So hopefully these stories that we exchanged and we heard from Gail, from patients, that these stories give you a sense of the scale of the challenge before us, but also give us all energy that comes from taking the time to connect with each other and hear each other's stories. So we want that kind of energy to spread across the province. That's why we need you to think about who you might be able to bring together for similar discussions. And just like I mentioned, it could be your faith houses, it could be at your house, it could be at your union hall, it could be in your local community center. And we want to support you in bringing people together. Now, if that seems intimidating for you, we'll be organizing a training on this very same day and time next week, specifically about organizing house meetings. So you can put in your calendars now. I mean, of course, we'll send out that date, but that's next week on Thursday, February 15 at 1 p.m. So that's when we will hold our virtual house meeting training. As well, the event page in our website also has our listening toolkit and some extra resources if this is something you're interested in organizing in your own community. So we're actually going to give you one more chance to fill out your commitment card. Maybe one of my coworkers can put the link in the chat again. And in fact, I was going to give us all a few minutes to actually click on the link and actually just start filling out the form. But I'm actually going to defer to Audrey, who has the next section here, just for time's sake, if we can take a few minutes to do that, or if we should just put the link in the chat and wrap up.
Thanks, Usman. Well, I think that's pretty much it for us. I just wanted to reiterate some of our next steps before we get going, but I did just put the link in the chat again, and that has the commitment card. And so there's some options for being involved in the house meeting campaign there, but also some other options for attending workshops. If you want to dig in more to the analysis that Ayandri kind of teased us, we're going to be putting some workshops together that will deepen our analysis analysis of what's going on and what solutions are. Also in the chat, I put in a PDF to our listening toolkit, which is the resource guide to organizing house meetings, and the link to the house meeting training page on our website that has all of these things in one place. And of course, as Usman said, we're sending this all up in a follow-up email. So if you miss it, the link in the chat, you'll get it in your inbox shortly. But to reiterate one more time, come to the training next week. It's going to be recorded as well. So if you're not available, you can watch the recording later. And download the listening toolkit and think through how you might be able to do this and who you would be doing it with. And then don't forget to put April 25th in your calendar, because that's when we're going to be coming back together and bringing all of this wealth of knowledge and wisdom and these powerful stories back together to talk about next steps. And I think that's really it for today. Thank you so much for taking time to build power today. The small group leaders, or actually really anyone, is invited to hang out for about a 10-15 minute debrief. If you'd like to stay on, it's optional. You're very welcome to stay. And if not, have a great day, and solidarity to all of you.